people about this. They may spot for weeks at a time. They may bleed 2 weeks and then none 1 and then bleed 3 weeks. And so it can be all over the place. And if they don't want that, they shouldn't get this option. Now, the interesting thing is after a year, about 22% will have no bleeding. So it definitely is advantageous for that, but you don't know if you're going to get no bleeding or if you're going to be the one that bleeds every day. I put on here weight. Okay, so weight's kind of tricky. Most of the hormones do not see a big difference with weight. Okay, so most of them are weight neutral, and this included. But some people always say they gain weight or they lose weight. So it still is a possibility. It's just not a big chance that they're going to gain weight on this one. And then the other concern is women or girls with BMI greater than 30. The studies after it came out show that it may be slightly less effective with a BMI over 30 over time as that hormone level drops. It's still good, it's still very effective. So I wouldn't change it for that reason, but it's just something to keep in mind. So, okay, now we're moving on to the tier 2. Depot-medroxyprogesterone acetate. So that's the injection you get every 12 weeks. And again, it also suppresses ovulation. So your hormones are like this. This is a whopping dose of hormone. So it's a lot of hormone. I don't usually use this unless I've tried something else first, just because once I give it to someone, I can't take it back. And some of these side effects can go on for a good 9 months. If it's the irregular bleeding, I'll sometimes try the birth control pill with it, or I'll try an estrogen patch and see if that improves it. But some of these other things, headaches, depressive symptoms, anxiety, it's hard to get rid of those. Weight gain. This is the one that definitely has a higher chance of increased weight. So you need to tell teens about that ahead of time. And most of the studies show that if someone is already obese, they're more likely to gain weight, or they're able to gain more weight than if they have normal weight to begin with. So that's the other thing to think about. A lot of people are concerned about the risk of bone thinning with this. And we do see in the studies that once they stop it, their bone density goes back to normal. So it seems to only be an issue while they're on it. Okay, here comes the confusing part, birth control pills. There's just a lot of them, and they all have subtle it's just everything is slightly different. The bottom line, again, is it suppresses ovulation, so that's its main mechanism for birth control, and it has estrogen and a progestin. They have monophasics and triphasics. I really prefer monophasics. I think you can manipulate them more, and if they miss pills, they're less likely to get messed up, and they're less likely to take the wrong pill if they're pill swapping and doing all that stuff. So I recommend monophasics. And then there's all sorts of different regimens. So it was originally started with 21 days of pill and then 7 days of placebo. That was just to mimic periods, which, I mean, there's nothing natural about this. So why mimic something that's kind of annoying? So I prefer these other methods. There's different things you can do. You can shorten the placebo days. There's some pill packs that automatically have 4 days only of placebos or 5, or may have estrogen and placebos in them. And then otherwise you can do it on your own too. You can just tell them how to take the pills if you want. And then there's extended active pills. You can take 3 packs at a time, but you can do anything. You can take 2 packs at a time on placebos, 4 packs at a time on placebos, or you can do continuous active pills, where you take no placebo pills. We're not seeing increased risk of blood clots or any other big risks with these. And it may be slightly more effective when you're looking at a BMI over 30 again. So that may be something to think about too. And okay, so now what's in the pill? So you have estrogen. The main one is the ethinyl estradiol. And this is all low dose, so any of these are okay. Different reasons to pick a low or high one. The 10 microgram is a brand only, low estrin, and so it's more expensive. It may not be covered by insurance, that type of stuff. These other 2 pills right here, estetrol and estradiol are in these. These are brand only, Nextstellis and Natasia. What they were trying to do was to decrease the breast effect and the thrombotic effect. And in animal studies, the estetrol may do that. And now they have to do a lot more human studies to see how it works in real life. So breast cancer is affected by all hormones. I mean, it just is. But what we're seeing is there may be a slight increased risk with any of these hormonal options. Usually when you stop it, it slowly goes back to their normal risk or their prior risk of breast cancer. So, you've got to look at all the pros and cons to all this and decide about their risk factors and everything. But again, these are more expensive because they're not covered by insurance. You can look on the website and look for coupons and such, though. And then the progestins, this is another complicated issue. The first generation is the ones that came out first, and then it goes down from there. The bottom line is they're not that much different once you add the estrogen, okay? So the estrogen makes up for a lot of the side effects of the progestin, and it usually doesn't make a difference. But I think about it, if someone has certain symptoms already, or they have certain side effects that are bugged. Norethindrone, ethinyl, diacetate, they've been around forever, and I think they're tried and true. These two have more androgenic effect, okay? So progestin pills can have affinity to the progesterone receptors, estrogen receptors, androgen receptors, and mineralocorticoid receptors. And each one of them has a little bit different effect. The further you go down, the less it affects the androgens and the mineralocorticoids. So these ones are almost anti-androgen, which is nice. So these are all things to think about depending on what symptoms people have and what side effects they may get. Okay, so let's see, it's not switching. That's, oh, hang on 1 second. I might have bypassed it here. Okay, so we've got benefits. So you've got the progestins that do some good and the estrogens that do some good. So this is all listed here. And then you have possible adverse effects. And interestingly, you have some of the same things on both slides because hormones affect everyone differently. And so sometimes you don't know until you try this and see how it goes. So what do you do if you have someone with side effects? Breakthrough spotting, super common. If you ride it out a few months, it usually gets better no matter what. If they're doing extended pills or continuous pills, it's better to use the higher dose, 30, 35 microgram pills, because you're more likely to spot on the 10 and 20. So that's just something to keep in mind. Breast pain, headaches, nausea, depression, all these things you can try to lower the dose and see how they do. But this first category here, breast pain, headaches, nausea, a lot of times that'll get better after a month, so you can see how you do. And then sometimes if you take it at night, it does a little bit better also. The depression, anxiety, weight gain, bloating, edema, sometimes these are deal breakers. And you can try to lower the dose, or you can try to put it, use a different progestin category. But the same thing may happen. You don't know until you try it. It's all trial and error, and you got to give it a few months each time. That's the problem. Sometimes 3 months feels like 20 years. And then these other things at the end here are mainly trying to decrease estrogen to see if that will improve libido, possibly, and melasma. Acne is the one that you want to go up on the dose. And again, you may want to look at less androgenic type progestin or just a lower progestin in general. So what are we concerned about with the pill? Who do we not want on the pill? So if they have high blood pressure, they shouldn't be on the pill. DVT risk is the other big one, and it's low. It's, it's 3 to 20 and 10,000. So it's quite low, but if you're the one that gets it, it's serious. If you look at those progestins as you go down in the, first, second, third, fourth generation, as you go to the third and fourth, they have a higher risk of DVT. But really, does it matter if it's 3 in 10,000 versus 20 in 10,000? Not so much. But I do tell them that, so they're aware of it. And okay, obesity is another hard one with the pill too. So none of the pills were studied that way with BMI greater than 30. They were all BMI less than 30 when they first came out. But there are studies afterward, and they show a slight increased risk of pregnancy in many of the studies. Some are neutral, some show slight increased risk. But at the same time, you have a slight increased risk DVT risk just being obese. So, you think, okay, I'm going to go up on the pill dose, but then that also slightly increases DVT risk. So it's kind of a catch-22 you get into. What I usually do if they're obese is I try to do shortened placebo days and either extended or continuous. So they're taking the pill more and likely will have a higher birth control effectiveness. Then if they're on any seizure medication, remember you have decreased effectiveness of the pill. So it's important to either have them use condoms also or look at a non-oral route. And then if they have any liver disease, you need to look at should they be on this or not. When it comes to obesity, again, weight gain is neutral. Okay, so the pill, most of the studies show neutral weight gain, but you're going to always get someone that says, I gained weight on this. So that's where you could look at using a lower estrogen or a different progestin and see if that helps them in their specific situation. Okay, so I use the birth control pill probably more for medical reasons than actual birth control. And there are many, many reasons you can use it for. The biggest one is painful periods that you'll see with teens or heavy periods or irregular bleeding. And you can use regular traditional method. You can use shortened placebos days. You can use continuous or extended. For most of these problems, I like to use a shortened placebo day. So I'll try to do 4 days instead of the 7. And I try to do extended or continuous. The ones that I really like to do continuous active pills on would be challenges with menstrual hygiene. So if you have a teen that's developmentally delayed or physically challenged, and it's difficult with them during their period when they bleed, I try to get them to not bleed. Same thing with menstrual migraines. I don't want that hormone drop, so I'm going to try to do continuous. Recurrent ovarian cysts, the same thing. Lifestyle needs, so that's an elite athlete that's training, someone who's going to Timbuktu and doesn't want to bring a lot of pads or tampons, that type of thing. So you could do menstrual suppression for them also. And then medical or psychiatric conditions. So POTS syndrome, that can get worse around your period. Depression, anxiety, OCD, all that kind of stuff can get worse around the period. So a lot of times I'll try to eliminate their period and not let that hormone drop. So these are all important things to consider. A lot of the dermatologists are giving the pill for acne, and that's their main indication for it, and that's okay. That's totally okay. It's an acceptable indication. The patch. Okay, so the patch is like the pill, except you put it on, and you can put it on your arm or you can put it on your lower abdomen. Ortho Evra was the first patch. It's no longer available, but they have generics of it now. But the problem is, you can see right here, you get 60% more estrogen than the 35 microgram pill. So that's higher than the low dose pills that we want to use. So I try not to use this if I can help it, but sometimes that's the only or best option to use. So again, you just have to look at all the, pros and cons to everything. There is a newer pill, Twirla. It's brand only, so sometimes it's not covered. So I usually write for this one, and then if it's not covered, then I may do the generic of this top patch. The crazy thing is both of them have labeling that says should not be used if the BMI is greater than 30. It's in the little black box warning. And they say because it may be less effective. And then they also say may be higher risk of DVTs with BMI of greater than 30. So I still use it. Sometimes that's the only option. So you've got to look at the pros and cons of everything. The ring, just like the pill, and you can manipulate it any way you want, just like the pill. You can do continuous, you can do leave it in for 4 weeks because there's a little bit of hormone in it, and then switch it out every 4, or you could switch it out every 3 if you want to keep the higher level hormone. And then the new pill or the new ring is this Anovera, which you can use for a full year. You should not take it out any more than 2 hours at a time, except for that 7-day leave. But again, I don't like to do a hormone-free time for 7 days. I think they just get a lot more symptoms and side effects. So when I use these, I shorten that or do extended use. And okay, so I just want to bring out, you can look online or you can use their app and look at this medical eligibility criteria. It's important that you do due diligence about looking for what may be a contraindication. So the 3s and 4s are what you don't want to have, right? What's a 3 and 4? So the big one I want to point out is this migraines with aura. Okay, they can be healthy, they can have no other issues, but if they have migraines with aura, they should not use combination birth control pills. And then all of the other issues that may put them at higher risk of thrombotic events is the other thing. I did want to point out that they use a 2 for BMI over 30 for birth control pills. So this is, CDC US recommendations, and that is what I go by. So that's why I still feel like I can use the pill, patch, ring, all those, even in obesity. Okay, the other thing to remember is there's progestin-only pills. So if they don't want any of the implants, injections, IUDs, and they can't use estrogen, there is progestin-only pills. The mini pills, what's been around forever, but it is a low dose. So you get a lot of breakthrough bleeding with it, which is annoying. I actually often will prescribe 2 a day, and then I tell them, I tell them that the pharmacist is going to say your gynecologist is crazy, you're only supposed to take 1 a day, and I explain to them we're doing 2 a day. It might be for medical reasons, or it might be because they're having side effects with bleeding, and they may actually have better birth control effectiveness with it as well, and they may get less side effects. So I do 2 a day at times if this is the only option for them. The one I really like is the second one, drospirenone. So it's 24 days of active pills and then 4 days of placebos. So this is SLIND. It's brand only, unfortunately, so it's not covered by insurance a lot. It does have coupons, on its website that you can get that they can usually use for a year. It suppresses ovulation, so it's different than the mini pill. And so you get a lot less side effects. And it's the only pill that looked at BMI greater than 30, and it was shown to be the same effectiveness. So that's another huge step for that. And that's SLIND. It's a brand only. Okay, I do want to point out too that sometimes something happens and they need emergency contraception. So there's different options. If they're already on the pill, they could do the birth control method, but that you've got to use, if they're on the 20 microgram pill, they will need 5 of those, and then they repeat it in 12 hours, another 5. So you're going to get a lot of nausea with that. So just to point that out. And then this levonorgestrel was Plan B. Now they have other options, other brands, but it originally came out as Plan B. And that is a good option. It's over the counter, so you don't need a prescription. And then these other 2, obviously you need a prescription. You need to get put in. The copper IUD, Mirena, Loletta could be used up to 5 days. And then the ulipristal, that's the Ella, that can be used up to 5 days. But you don't want to use that if you're using a progestin type method, because that counteracts what may have been working for that. So that's mainly, if you have condom break or you didn't use anything, or another, IUD fell out or whatever, that type of thing. Okay, so that's all I'm saying about the birth control. There's a lot more I could say. Uh, just to point out a little bit about CD recommendations for STIs now. Minors can consent for their own STI services, which we already all know. Their latest recommendation was 2021, and so annual screening is recommended for girls, for chlamydia and gonorrhea. Annual, okay, but then they also say annual screening is recommended for any high-risk patient. So it's a discussion about what's high risk and such. HIV screening is recommended and offered to all adolescents, but they don't say annually. They just say it should be discussed and offered. And then HPV vaccination is recommended, which is a huge, you guys are doing great with that. I love it. When it comes to treatment, so if they get a positive for something, then you should offer other STI testing. And then so specifically for chlamydia, it's best to offer expedited partner therapy. And I do, so if I'm gonna prescribe doxycycline, I'll write for 28 tablets instead of 14. And then in the comment section, I just say expedited partner therapy. And I haven't had an issue with it ever. The other thing is you're supposed to, CDC recommends that you give information about the disease, the medication, warning signs and symptoms. So somehow give them a paper or print it off in the ABS, get something to them so they have that information that they can show their partner to. And then you should always offer repeat testing in 3 months, and that is for reinfection, not so much test of cure. So again, chlamydia right now, they're recommending doxycycline, but you can use azithromycin. I try not to use the fluoxins. They just have too many risks associated with them compared to the other possible medications. And then you want to make sure you remind them nothing for no touching for 7 days at least, and then repeat testing. Gonorrhea has a lot more resistance, unfortunately. So it's got an injection for its main treatment, ceftriaxone. And then again, retesting in 3 months. If it's pharyngeal, if it's oral gonorrhea, then you should retest them in 7 to 14 days because higher chance that it's not gonna take care of it. And let's say someone gets gonorrhea or chlamydia and they have an IUD. You treat with the same antibiotics and you can leave it in place. If they have symptoms and they're not getting better at 48 to 72 hours, then you consider pulling it. But it is okay to leave it, which they've been saying this for a while now, but earlier on they were saying you got to pull it right away. No longer. And then trichomonas, they go back and forth on this, on the medication recommendations for this too. So you've got mainly for females now, you want to use the week-long treatment. It used to be the 1-day treatment, but now it's the week-long. And then for males, you use the single treatment. Again, you've got to talk to your patient to see what they're going to do and not do. And if you use something else, then you should probably check them sooner rather than later. And just a reminder with herpes, it's good to do, if you're doing a swab test, do the type specific testing so we can see if it's HSV 2 or 1. 2 is, it's much more aggressive. It has more recurrences, it has more shedding. It's going to bug them more. It's going to bug the person they give it to more. So it's good just to know the difference, but either way, you treat them the same. And you have suppressive therapy and episodic therapy. And the suppressive therapy I like to use for the first year, but just because they're going to get more recurrences that first year, and then often they'll get less over time. But they can decide if they want to continue it after that or not. And that's it. I'm a member of NASPAC, that's the North American Society of Pediatric and Adolescent Gynecology. It's got a lot of good handouts for kids' problems with gynecology and teens, okay? And then our ACOG website does as well, CDC, and then the Society of Adolescent Health and Medicine has a lot of interesting stuff on it too. The other thing to think about is Planned Parenthood. That has a lot of good information for patients, how to do things exactly, how to use all the birth control, and it talks about STIs as well. And I think I've got a slide with references. And that's it. So I'll take any questions you have at this point.
Thank you, Dr. Katie. We do have a handful of questions in the chat. The first one is from way at the beginning of your presentation. If starting a Manera, you said that they can continue their OCPs for 2 to 3 months at the same time to help with the transition. Is that correct?
Yes. Yeah, so if they're on birth control pills, I tell them to keep going for 2 to 3 months, because then they'll get through that yucky period of weird bleeding and they're more likely to like the Mirena, and then they can just stop it after 2 to 3 packs. Now, if they start to get migraines with aura, I have them stop it. So as long as they don't have a contraindication.
Thank you. The next question is, so do I understand you would advise against even starting Depo in the first place?
I don't advise it. I usually look at the other things first. Do I give it? Yes. And have I given it as first option? Yes. So it's a discussion. It's what is going to work best for them. And sometimes they say, I won't do this, I won't do this, I won't do this, I want to do this. And so we do that. But again, you just want to make sure they understand that they've got that it's going to be in their body for quite a while and I can't take it back. So it's not one of my first choices. That's kind of the bottom line.
Next question. I thought the party line is that OCPs don't cause weight gain.
That is the party line, and that's what the studies show, that it's neutral, weight neutral. But you have teens and women continuing to list that as a side effect, weight gain. I didn't have it before, I had it right after the pill. So there is potentially there are some women or some teens that gain weight on the pill. It's not the majority, it's a very small minority, because there's so many other factors, especially as a teen. It's really hard to sort out. But yes, they are considered to be weight neutral.
Great. The next question is, can you speak to the best option for menstrual suppression for trans patients?
So again, you got to talk to them about what's a deal breaker. I have some on the pill because we're getting the best no bleed, because a lot of them will get dysphoria when they have bleeding. So I end up sometimes the pill works the best to give them no bleeding. Sometimes we'll do Depo, medroxyprogesterone acetate. So you want to talk with them and get a feel for what works for them and what doesn't. But you can use Depo medroxyprogesterone. You can use the pill. Again, talk about the pill because it has estrogen and some don't want estrogen. And then the progestin IUDs work really well. The Nexplanon I don't normally use because that bleeding often just reminds them that's not what they want to do and it keeps happening. So I don't usually recommend the Nexplanon.
Are there any good books or resources for adolescents and teens to improve their knowledge about the pelvic floor and pelvic floor symptoms? I typically recommend Below Your Belt, but would love to have other ideas.
That's the one I usually talk about too. It's hard to find books and they don't want books. They want online stuff and that keeps changing too. So I don't have great things for pelvic floor for teens, unfortunately. And I do, if like some of them will have chronic pelvic pain, dysmenorrhea, endometriosis and such. And sometimes just having them go to a physical therapist where they're talking about it and doing things is better than reading about something. There are, I'm trying to think if there's, I can't think of it. I'll try to be thinking about any online resources that I have. I have them somewhere, but not in my head right now.
One more question in the chat says, with Nexplanon bleeding, do you recommend using OCPs for irregular bleeding or NSAIDs?
All of the above. I often will just try to do the pill if they don't have a contraindication, and I'll do 2 to 3 packs because sometimes a little bit of estrogen helps. And I do continuous. I don't have them take the placebo a week. I have had them use NSAIDs. There's been a couple small studies looking at doxycycline to try to do an anti-inflammatory to see if that makes a difference with IUD or Nexplanon, but I don't use that. So I think you can do the pill or the NSAIDs.
So those are all of our questions that were in the chat. If anybody else wants to come off mute, if you have any other questions, or we definitely still have time for that.
I have a question going back to that last one about the using OCPs with Nexplanon. Would you recommend doing 2 to 3 months of the OCP at the time that the Nexplanon is placed?
I don't normally, because it's not just at the beginning that you may have the irregular bleeding with the Nexplanon. It can be any of the time. So some get no bleeding that first year, and then all of a sudden the second year they start bleeding. So I don't think it makes a difference to start it at the beginning automatically without seeing what their bleeding pattern is going to be. But that's an idea. You know, you've got to kind of, will that help them keep it longer? Maybe, but you don't know even that they're going to have the irregular bleeding from the get-go. And I have had some, okay, I admit, I've had some people who are on the pill longer than 3 months because they want something effective and they just like how they feel on the pill. So I've had some people keep going on both.
We have one more question in the chat, Dr. Keating. Do you have any specific tips or processes to discuss LGBTQ plus inclusive sexual health topics with your teens?
Can you say that again?
Do you have any specific tips or processes to discuss LGBTQ plus inclusive sexual health topics with your teenagers?
Okay, so and that's part of that conversation at the beginning. I try to get a feel for, you know, how they identify and what type of relationships they want or they're in, because sometimes they're in a male-female relationship, but that's not what they want. And so a part of it is just asking. And you know, it's, I think with teens is you can ask whatever. They're either going to answer you or not, but I feel like it's more of an open topic with teens than older women. And so some may get more offended when they're older, but the teens really, they'll just answer you because they know there are all types out there, which I love. I think it's much more open. So I think the big thing is just asking. That's, you know, what their identity is, what their relationship is currently, what they want for relationships, so you have an idea. And then the big thing again is what is, you know, if you have a trans patient, what's gonna bug you the most? What do we want to avoid so we can get you in a better place?
Thank you. Any other questions?
Nothing?
Well, thank you, Dr. Keating, very much. And thank you to all of you who have joined today. You will be receiving some information about continuing credit or continuing education credit, and then also we'll have access to the PowerPoint for the future.
Cool, thank you.
Thank you so much. Bye-bye.